Welcome to the Long COVID and Post-Infectious Syndromes Echo, a collaborative effort between the University of Utah and Bateman Horne Center. I'm Clayton Powers, full-time physical therapist at University of Utah and also education liaison for Bateman Horne Center. I'm joined by Sarah Day, Project Echo lead at University of Utah. Today, we're privileged to have Dr. Lucinda Bateman presenting on sleep dysfunction in long COVID ME/CFS. Dr. Bateman is an internationally recognized researcher, clinician, and educator in the field of ME/CFS and related conditions. She's the founder and chief medical officer at the Bateman Horne Center and has spent more than 2 decades advancing patient-centered care research and medical education. Dr. Bateman is a principal investigator for the Long COVID Recover Energize trial and has advised federal agencies, including the NIH and CDC, and is widely respected for her leadership in expanding clinical understanding and improving outcomes for people living with complex chronic illnesses. Dr. Bateman, thank you for being willing to talk to us today. Go ahead and share your slide. The time is yours.
Thank you so much for that very kind introduction, and it's a pleasure to be here. I want to talk to you today about sleep disturbances, and this is a very, very broad topic that we cannot possibly cover in this short time. So what I'd like you to come away with is an awareness that sleep disturbances are important in our patient population, and that you really should dive in and be as helpful as possible in helping them. And that's what I hope to leave with you today. So before we're done, I want you to learn about the presence, that they are present, sleep disturbances and unrefreshing sleep in long COVID, ME, CFS, and related conditions. I'd like you to kind of consider some of the causes. Although we don't know all the causes, there are many things that we can understand and use to direct our decision making. We'll talk briefly about how sleep disturbances are evaluated. I also want to emphasize, just before I go through these, that I'm not going to spend majority of the time on things that we already know and are taught in medicine about primary sleep disorders. I'm going to assume you have a background in that, and I'd like to talk about the aspects of sleep that are less well understood. So then the next question is, does treating sleep disturbances change the prognosis? Is it helpful to treat? And I'll try to make the argument that I think it is. And then what are some reasonable treatment approaches and supportive care that don't fall too far outside of evidence-based medicine? So number one is, are sleep disturbances present in long COVID, ME/CFS, and related conditions? And let me just give you a little bit from the evidence base. This is a diagram from the National Academy of Medicine report on how to define long COVID. And all I want to show you over here is that sleep disturbance on the left with a little box around it is listed as one of the primary symptoms of long COVID. The next is really, I just picked one of the papers I looked at on sleep disturbances in COVID. And this paper in the Journal of Clinical Sleep Medicine, published in just about a year ago, said that sleep disturbances have a high prevalence in patients with post-COVID conditions or long COVID, occurring in upwards of 70% of patients, and that sleep problems rank third behind fatigue and shortness of breath or dyspnea in a meta-analysis. And they noted that significant comorbidities of insomnia at the initial visit were symptoms of anxiety, depression, and PTSD. But the most important thing is that chronic insomnia correlated with worse ability to resume usual activities and worse overall quality of life. So function and quality of life are very, very important, and it's worth addressing these. I also want to point out that of the 5 major clinical trials that Recover COVID is doing, these are the federally funded trials for long COVID. One of the 5 is called Recover Sleep. So when they were designing these trials, sleep was right up there, and sleep disturbances. And they're enrolling more than 1,000 participants around the country in these 2 arms. One is people who sleep longer than usual, are very sleepy or tired during the day. And those patients are being treated with modafinil. And if they can't tolerate modafinil, then solriamfetol, which is Sunosi. And then the second is complex sleep disturbances, poor quality sleep. That's basically melatonin and light therapy and sleep hygiene. And it's also important to notice that all patients enrolled were first being screened with polysomnogram to assess for obstructive sleep apnea and central sleep apnea. So we'll have this study results at some point with a lot of information about sleep in long COVID. What about ME/CFS and fibro? Well, the sleep disturbances are so common, they're included in all the case definitions. Any case definition of CFS, ME/CFS, ME, and fibromyalgia has unrefreshing sleep or disturbing sleep as a primary criteria for diagnosis. And the sleep is abnormal both in quality and in duration or timing. Very broad array of sleep disturbances. This is a paper I reviewed when we were doing the Institute of Medicine report, and I helped on the section with sleep. And this was a particularly interesting paper published back in 2013 in the Netherlands. They were testing everybody with chronic fatigue with sleep studies. And of course, there was a high prevalence of primary sleep disorders. But then they started saying, well, what about these tired patients that don't have a primary sleep disorder? And so they looked at the polysomnography of 300 ME/CFS patients that did not have a primary sleep disorder, like obstructive sleep apnea, central sleep apnea, or restless legs. And they really kind of fell into four groups. People who slept too much and had too much REM sleep, people who had no REM sleep, people who are sort of light and had multiple arousals per hour, and then people who just couldn't sleep and didn't get enough REM sleep. And those brackets on the right are my own comments. They're not from the paper, just basically from my experience with patients, because we see it's not necessarily that someone will fall in one of these categories and stay there. Sometimes people cycle through these categories of sleep. But the point is, it's a very significant problem. This diagram comes from the Institute of Medicine report, Beyond Myalgic Encephalomyelitis Chronic Fatigue Syndrome, Redefining an Illness, which was really to establish clinical diagnostic criteria for ME/CFS and published in 2015. And this is figure 4 from the paper, but it's really using the research of Lenny Jason, which is the reference on the right, to show that even though sleep problems are very generic and happen to a lot of people, if you screen to see if it's at least moderate to severe and occurring at least half of the time, it separates patients from controls quite well. So the green bars are the CFS patients, the red bars the controls. But it's interesting because unrefreshing sleep, like 90, I've got my bar up there. Let me see if I can move that over. 92% of people in the study espoused unrefreshing sleep. But you can see there's a big variety of kind of sleep things that led to unrefreshing sleep. Problems falling asleep, need to nap, problems staying asleep, waking up too early, and sleeping all the time. So this is, again, the range of sleep problems that's well documented in this large review study. So with that overview, what are some of the causes of sleep disturbance in long COVID and ME/CFS and related conditions? And again, I just can't emphasize enough that primary sleep disorders need to be screened, and they're more common than in the general population. So obstructive sleep apnea, central sleep apnea, and movement disorders. But again, I'm not going to focus as much on that because I want to talk about the things that get overlooked. And that may be sleep disturbances due to chronic pain, mental health conditions, urinary frequency disorders, medications, disruptions like a snoring spouse or active pets. I just want to plant in your mind that there are many things if you take the time to look at what the potential causes are. But for a minute, I want to talk about what may be unique disruptors of normal sleep in long COVID and ME/CFS. Just a quick overview. And that involves central sensitivity, autonomic nervous system dysregulation, and HPA axis dysregulation. We'll just spend a minute talking about each one. So central sensitivity, I just picked this one paper because I thought it was very unique. And this was a paper by Don Goldenberg, again, published in 2025. He's kind of the father of fibromyalgia, but he published this paper called The Pivotal Role of Central Sensitization in Long COVID, Fibromyalgia, and Myalgic Encephalomyelitis Chronic Fatigue Syndrome. And he said in the paper, the clinical and pathophysiologic features of long COVID, fibromyalgia, and ME/CFS provide a unique unifying framework of central sensitivity syndromes. And that his expert opinion is once long COVID is redefined to exclude patients with well-defined organ disease, it fits best as a model of central sensitization. And I do believe central sensitization plays a really important role. And fibromyalgia is really the long-term model for this of central sensitivity. So here's the second category, autonomic nervous system dysregulation. There's a very good documentation in the ME/CFS community about the imbalance of sympathetic and parasympathetic nervous system. And I put in as documentation for ME/CFS a paper that was fairly recently published called Autonomic Dysfunction in ME/CFS, and this was a long-term paper published by this was the multi-site clinical assessment of ME/CFS that was done in multiple clinics in the US sponsored by the Centers for Disease Control. We were one of those sites. And this paper documented there was really substantial autonomic symptom burden that correlates with greater illness severity in ME/CFS. And they encourage individualized care strategies targeting dysautonomia assessment and intervention to offer meaningful improvements in symptom management and quality of life. So this isn't directly about sleep, but we know now that autonomic dysregulation is playing an important role. What about long COVID? I want to use a paper to illustrate this. That was a very important paper from the American Heart Association in 2024. The title of the paper is Cardiac Arrhythmias and Autonomic Dysfunction Associated with COVID-19, a Scientific Statement. And what they said in the section on autonomic dysfunction, that POTS occurs, or postural orthostatic tachycardia syndrome, occurs in 25 to 35% of patients with PASC or long COVID. Orthostatic hypotension occurs in 3 to 5%, and orthostatic intolerance without tachycardia or orthostatic hypotension occurs in 50 to 55%. And I want to this is a diagram from that paper. And you kind of look on the left and you can see that we still don't know exactly why it all happens, right? There's tissue injury, immune-mediated mechanisms, deconditioning, and a number of factors feed into long COVID. But if you look up in the box, it's kind of stunning that it's not all POTS. It's very common to have autonomic dysfunction. Some of it is associated with rapid heart rate response to orthostatic stress. Some of it to the brown is orthostatic hypotension. But look at that green area. That whole green area is orthostatic intolerance or autonomic dysfunction with normal heart rate and normal blood pressure. So there's a lot of dysautonomia going on in our patients, even if they don't meet POTS criteria. So I hope I'm convincing you about these major categories of central dysregulation. And the third one is dysregulation of the hypothalamic pituitary axis and hypothalamic pituitary adrenal axis. We know from many decades literature of ME/CFS that there's a flattening of the cortisol curve. So I've got, this is a normal curve on the left. I put the arrows in to show that curve, that the cortisol should rise early in the morning and then drop down and drop to its lowest by night. But these are kind of flattened out a little bit in ME/CFS. This creates we think that it's centrally mediated, that there are basal levels of cortisol, but the body can't respond to stress, has abnormal stress response. And on the right, this is from a paper published by the CDC in 2008. They did a large population-based study and showed that It's kind of hard to read, but those are salivary cortisol levels throughout the day. So you can see at 6:30 a.m., the CFS is lower than no fatigue or that ISF is insufficient fatigue to meet ME/CFS criteria. And you can see it's a little bit lower. And then toward the end of the day, the chronic fatigue syndrome levels are a little higher, don't come down quite as low. And I wanted, this is a question in long COVID right now. There were some papers that came out saying that there was low cortisol based on AM cortisol. Then there was a paper published that said it wasn't true. But if you want to read about that, I would read the paper by Armin Aladini, which is the lower reference on the right, which is a really good discussion of how hard it is to understand cortisol levels. But this is a real result from one of my patients. This is a 33-year-old male with ME/CFS who'd been sick for 2 years, and he had salivary cortisols done in the morning, noon, afternoon, and nighttime. And I put down below is the curve, and I helped you with the red lines. So the others are low and high values for normal, and you can see his morning cortisol is very low. It kind of stays around during the day, and it's a little bit, his does go down at night, but there's just something wrong with the signaling. And studies in ME/CFS showed the adrenal function was normal. This was really just from abnormal central signaling and stress response. So I think we'll see that in long COVID. So how do we evaluate sleep disturbances? Well, the gold standard is polysomnography. You can also do home sleep studies. You can do overnight pulse ox. And I like to have patients participate in monitoring their own sleep if you can find ways to do that. And just a word about polysomnography. Polysomnography is to diagnose primary sleep disorders that can respond to treatment. But polysomnography is otherwise non-diagnostic in ME/CFS and fibro, and probably long COVID, because what it shows is similar to sleep artifact. When you go to the sleep lab, you don't sleep very well, right? And what we see in the polysomnograms of ME/CFS and fibro is alpha wave intrusion, so too much light sleep, almost being awake, not enough delta sleep, which is slow sleep waves, fragmented sleep, and delayed onset. So it's a challenge, right? And maybe all of those causes may be playing a role, or varied causes are playing a role. I also want to put in a word for really being able to take a good history and understand the difference between being sleepy and tired. So we talk a lot about fatigue, but when we're talking about sleep deprivation or sleep problems, it makes people sleepy during the day or somnolent, and they're not the same thing. And I like to ask about this because if patients are somnolent or sleepy during the day, there's some kind of sleep deprivation going on. Sometimes it's related to medications and sometimes to acute illness like mono. But the differential for daytime sleepiness is a lot more concrete than daytime fatigue, which is hard. And we use the Epworth Sleepiness Scale to help identify sleepiness in patients. And it's easier to treat. Okay, the harder question, does treating sleep disturbances change prognosis? And I will say we don't know. We really don't have good trials looking at drugs or other interventions in ME/CFS or long COVID. We do have some studies in other settings, but there haven't been good studies to show that if you do treat sleep, does it change function or quality of life? And there are more studies in fibromyalgia, and we'll look forward to the Recover Sleep trial outcomes. But I want to tell you my clinical opinion for being in the field a long time. I believe treating sleep skillfully helps improve quality of life and gives patients some control over their challenging multi-system illness. It's one of the things you can moderate, and establishing more restorative sleep, it may never be perfect, translates into better function, better cognition, and fewer symptoms during the day. We know in fibromyalgia literature that it definitely reduces pain to have more restorative sleep. So what are reasonable treatment and supportive care approaches? Well, some of that is a matter of opinion, right? It starts really with taking a really good history. So this is what we've done in our clinic, what I did in the past. We asked people to assign frequency and severity to all of these symptoms of sleep. So, zeros or none, 2 is moderate in severity or frequency, and a 3 is that the symptom is frequent or severe. And let me just show you how you can use something like this to get a good idea. Of course, you could ask a history, right? It just takes longer, right? If we use this to screen and then we can talk. So this is a patient that can't go to sleep, wakes up too early, can't get back to sleep. I mean, they have insomnia, right? Kind of what we think of traditional insomnia. But look at this person. They're complaining about their sleep, but they sleep all the time, right? This person has unrefreshing sleep, but they feel like they need too much sleep and they need to take naps. That's a really different animal, right? Who might still, this is a kind of unrefreshing sleep. And what about this person? This person has restless sleep. It's creating unrefreshing sleep. They've got restless legs and leg cramps, and they can't get back to sleep. And so you might address this a little differently, someone who has movement disorder and restlessness overnight. So general recommendations, and again, this is going to be kind of high level because it needs to be individualized to the patient. And you always start with sleep hygiene, right? Helping them have routine timing, environment, look at things that might be stimulating on sleep and caffeine and medications. And people should try not to nap during the day and be as active as their symptoms permit. But don't go into post-exertional malaise, because with ME/CFS, if you do too much and you develop post-exertional malaise, then it dysregulates your sleep even more. It's important to minimize sedating drugs during the day and aim at the causes of sleep disruption the best you can with the best history you can and discussion with the patient. And then remember, there are different ways to intervene in sleep, right? Helping people get to sleep is one thing. Treating light sleep and frequent awakening might be totally different. And then people who have early morning awakening, again, there are a number of things that might be contributing to these types of changes in sleep. So I just want to talk about meds that are available to us already based on disorders that sometimes can be used effectively in sleep. So for example, I'm skipping primary sleep disorders. That's big talk, right? You can talk about how we intervene in primary sleep disorders. But I will talk about restless legs. And the FDA has approved gabapentin I don't even know how to say that, enacarbil, which is Horizont. And we can use gabapentin and pregabalin, but they're not FDA approved specifically for restless legs, although they're used frequently. But those are meds that might help sleep as well as restless legs. There are FDA approved drugs for restless legs that are dopaminergic agents. And then there are other drugs used offline for restless legs, off label, sorry, that are used commonly and can be effective if the others are not. What about if chronic pain is present and you want to help people sleep? You want to treat their pain, but you also want to help them sleep. Well, there's a lot of FDA-approved medications for pain that also might help people sleep. It's not like you're just using a drug off-label for sleep. If you're using a drug approved for pain, that's also going to help them sleep, like amitriptyline or pregabalin or cyclobenzaprine, which has been approved for fibromyalgia as Tonmya recently. Topiramate for migraine would often help my patients sleep. And again, off-label, not FDA approved, we can use gabapentin for sleep, especially if patients have anxiety or pain or restless legs. There are muscle relaxants that are FDA approved for spasticity and muscle spasm that you can also use for sleep. And then there's a host of medications that are FDA approved meds for anxiety, PTSD, depression, bipolar disorder that can also be very effective for helping people sleep. So, helping people sleep is not always prescribing off-label if you're directing your treatment at the causes of sleep and being conservative in the number of medications you use. And yet you can empower patients to get better sleep. There are FDA-approved meds just for insomnia. Put them up here to remind you. The benzodiazepine receptor agonists like zolpidem. I like Zaloplan, which is similar, but only has a 2-hour duration. So if someone wakes up in the middle of the night and can't get back to sleep, you can give them a 2-hour nudge to get back to sleep without much hangover in the morning. I like to keep these drugs PRN and not put people on long-term doses because they develop tolerance to the drugs. There are 2 benzodiazepines that have FDA approved for insomnia, orexin receptor antagonists, and then, tricyclic antidepressant doxepin is a really effective drug in some patients for sleep in these super low doses, and it's marketed as Selinor. But you can buy doxepin in a solution and give people 1, 2, 3, 4, or 5 milligrams in a solution for very, very low cost without going to trade name drugs. And then, of course, there's melatonin receptor agonist, Ramelteon, which I don't particularly like. I don't think it works that well. I just use melatonin. So I threw this in because I found a review. It's kind of sobering. This was published in 2017 that looked at a large number of medications used for insomnia, chronic insomnia, not specifically our patients, right? And what I came away with is all of the they made some recommendations, but there was, based on reviews, there was weak data support for the use of any medicines. That doesn't mean it doesn't work. It means the evidence base is weak, right? And their suggestions in this paper were for sleep maintenance to consider suvorexant and doxepin. For sleep onset, consider Zaloplan, triazolam, Ramelteon, and also for both sleep onset and sleep maintenance is opiclone, which is Lunesta, zolpidem, and temazepam. Interesting, we use a lot of trazodone, and in this review, they suggested not using trazodone. And it was really because the evidence wasn't strong. Remember, these are guidelines that take the existing literature and try to tell us what we know based on the evidence base. That doesn't mean that they don't work, right? So I think what I'm trying to say in my talk today is be creative, understand your patient, understand their comorbidities, and see if you can nudge them toward better sleep with good decisions. And natural sleep, drug-free sleep is best. I will say that's true, but chronically disrupted or inadequate sleep may be insidiously harmful as well. And I've seen that throughout my career in fibromyalgia patients, in ME/CFS, and now in long COVID. Also, there's no perfect medication for sleep. Almost all have some adverse effects, and particularly in some people more than others. So what I want to do is encourage you, right, to think about sleep intelligently, try to help with sleep, and learn about medications and use them skillfully. So I'm going to end there, and let's see what kind of a discussion we can have or questions.
Thank you, Dr. Bateman. There's a few questions that have come up. One of them by Dr. Jeanette Brown was related to wearable devices, or a ring or other devices for monitoring sleep. What's your take on using wearable devices for that?
So I like wearable devices. I like patients to be part of the data collection, but you have to be careful. Number one is almost all those devices were not designed for people with these chronic illnesses. They were designed for healthy people, and they may give erroneous information, when they don't know that you have an illness characterized by HPA axis dysfunction and autonomic dysfunction and central sensitivity. So you have to take it with a grain of salt, right? And also, you don't want patients to become too anxious. You can actually get sleep anxiety by, following too much. What I like to have people do is kind of know what their numbers look like with their monitor. And then if they want to try a new medication, right, you can see, how does it change? Does it change your heart rate variability? Does it give you more sleep? Do you have fewer disruptions, right? So just big generalities. Because it's so expensive, we don't do sleep studies over, right? We don't send people back for polysomnography. So if we can find ways to monitor while we're making these decisions, right, about medications, I think it can be helpful.
Thank you. Yeah, I find that the wearables, sometimes they don't seem to be as accurate. They'll tell you, you got a great night's rest and you don't feel it. Or it says, oh, you got a terrible night's rest and you feel good that morning. So Toby Sawyer is asked, Is there any data or guidance on too much light due to the central sensitization interfering with sleep?
So I don't know, what I didn't do is a deep dive into any aspects of these things, right? For the purpose of this talk, just because it was way too much. Um, so I did refer to light therapy, right? But that's sort of, getting that light, like during for seasonal affective disorder, right? And then we've used that for a long time. But I do think that too much light in the room when people have central sensitization can interfere with sleep. And I have a patient who has hyperacusis, and they had to build her a room in the basement that was not only completely dark with no windows, but also soundproofed because any sound would keep her from sleeping because of her sensory sensitivities. So, yep, lots of people black out their windows and hang drapes and do everything possible to reduce how that has a negative impact on sleep.
That makes sense. Thank you. I'm going to spotlight Dr. Hoppers and Dr. Yelman as well as we have this discussion and we answer questions. You mentioned earlier this morning we had a similar discussion on sleep and how it's the holy grail if you can improve sleep, that it can really significantly improve patients' function. And so, what kind of tips or tricks do you use to help with sleep? I know you covered some. One you had mentioned this morning that I wanted to maybe have you touch on is using desmopressin for patients that have a lot of urinary urgency or frequency in the night.
Yeah, I'd be happy to comment. I want to say I only have one patient I do that in, right?
Oh,
But
okay.
she had really severe urinary frequency all night. And it was her main disruptor of sleep. This is an example of, haven't taken a history. What wakes you up? Why do you wake up so many times during the night, right? And try to get that out of them. And for her, if she had to get up, and that wasn't large volume or anything. So we just put her on desmopressin. Uh, and desmopressin, reduces the amount of urine that is taken out of the blood and fill your bladder, but you don't have to go. And it's FDA approved for bedwetting in children, right, to keep them from needing to go to the bathroom overnight. So that's just a creative example, right, of digging deep, trying things, but finally finding something that really made a difference for one person to get better, more restorative sleep.
Thank you. Dr. Hoppers or Dr. Yelman, can you touch on with medications, do people begin to develop they get used to the medications you use and you have to maybe rotate different medications for them for their sleep? Is that something you have to do?
I see that. Dr. Bateman mentioned this earlier in our discussion, and I was nodding my head because I was like, this is exactly what I do. I create a toolbox, and I sometimes have like, here's the simple tools, and here's the more complicated tools. If you're in PIM, you may need to reach for the ones in the complicated toolbox. If you're, in a good place and your sleep has been pretty good, maybe it's simply, glycine and GABA or something like that. And when you're more seriously affected, it may be that you need clonazepam and clonidine to reduce your autonomic dysfunction, and whatever else I may have them on. So absolutely. And I like to rotate because I find that frequently that some people will it doesn't matter what you do, eventually it quits working. So I like to sort of rotate through. And then some people, I'm like, we have a regimen that we can't deviate in any way. This is, we have to stick with this. I've started doing a little bit of more supplement use and, like Dr. Bateman was talking about, what measures can you do that aren't medications, make a routine at night, same time every night. The lights go low at a certain time. You know all the sleep hygiene things that you all know. Sometimes cool compresses can be helpful because that reduces their autonomic nervous system. But just kind of having a routine can sometimes give you that help as well.
I have a patient who was constantly cold because he was vasoconstricting, from his orthostatic intolerance, and he had cold hands and cold feet, and he just couldn't relax. So we actually had him take a hot bath at night, which makes him really orthostatic. So he had to crawl out of the bathtub and crawl to bed. So he didn't faint, but it helped him sleep because it warmed him up.
Mhm.
Right.
Wow.
Um, but again, you got to think about all the aspects, right? And like I said, everything can have its pros and cons, but you got to try to have a light hand, but see if you can improve the quality of sleep. I also, I didn't really talk about treatment of comorbidities in detail, right? But that's a good example is if you're treating autonomic dysfunction, there are certain things like clonidine, right, that both help and help people sleep. If someone's got horrible mast cell activation syndrome, they're going to be on antihistamines, right? So use a sedating one at night and a non-sedating one in the morning. Just common sense things.
Thank you. Dr. Brown, you have a question or comment?
Yeah, the other thing I'll remind people of too is like for restless leg, especially because long COVID impacts so many women. There are frequent iron abnormalities in that population. So looking for ferritin, iron supplementation, other things associated with that. But I see people use that they sort of get wrong that can actually make things worse that I'll caution people about is melatonin. I'm someone who has to adjust my circadian rhythm a lot because I do night shifts at the ICU. So I intentionally do what we tell you not to do. But melatonin supplements, many of them over the counter, are in way too high of a quantity, and people take them too close to when they want to go to bed. So basically, what you're doing is you're actually delaying your sleep cycle. And so there are some real problems with that. So if I have folks that want to try melatonin, I actually recommend getting the kids gummies because I find that they're actually the correct dose, which is closer to half a milligram to 1 milligram, and then take it 2 hours before your desired bedtime, which is also not how it's said on the bottle. And then if you take one of these, like ones that's over the counter, the max ones, they can be up to 15 milligrams, which can really give you that sleep hangover. They can give people the crazy dreams and stuff. And so I recommend people being really careful with their um, melatonin use because if anything, it can really backfire on people and make it actually worse. So just some cautions that way, just because I feel like the supplement industry is a little wonky and like the data on there is hopeful that way.
Yeah, thank you. All, how would you say low dose naltrexone affects sleep, or have you noticed that being beneficial for patients?
I'd love to hear from panel members too, but I'll share. But typically it varies a lot depending on the patient and their presentation. Um, we think of it as sometimes causing vivid dreams and causing some kinds of sleep disruption. And because of that, we start really low in those very sensitive patients and work up slowly. But I also have, and I've had patients that have to switch it to morning dosing because they just can't find a way to take it at night. On the other hand, I have a handful of patients that say they sleep way better when they take their low-dose naltrexone at night. And of course, we think it's reducing neuroinflammation, and it has kind of a variety of effects. But yeah, I've found it to be a valuable tool. I'd love to hear what the others say.
Think it's important to point out with low-dose naltrexone that some people report very vivid dreams, which can sometimes be disruptive to sleep. So you certainly have to pay attention to the dose, screen for those side effects, or consider dosing it in the morning.
Do they also find that the vivid dreams and stuff with dextromethorphan?
I don't see that much. Well, again, it depends on how reactive they are. What do you think, Dr. Yeoman?
I've heard it reported, but I think that it is important to recognize that there's a lot of vivid dreams in general for people with autonomic disruption. There's a very there's a subset of people with a very PTSD-like approach. And so it was already mentioned before, clonidine or prazosin or other alpha blockers, use of beta blockers, use of more broad-acting benzodiazepines can be really helpful for that type of presentation. And I would say that I personally often screen for fight or flight disruption, sympathetic overdrive, first and foremost, and use those medications before I turn to many of the sedative hypnotics and find really good efficacy. Clonidine's a favorite of mine, particularly sometimes I'll use a clonidine transdermal patch. You get a little more even distribution of that clonidine. And even though it's obviously on board during the daytime as well, it seems to promote kind of the natural sleep-wake cycle for patients.
Yeah, I like clonidine too, but remember that it can drop blood pressure, right? It is an antihypertensive. So you have to think about all aspects of the patient's presentation, and, pick the right one. And that's, what we all try to do.
Do you ever have clonidine withdrawal issues when you discontinue that, or with patients? Because that's always been an issue. Sometime I've seen when people suddenly discontinued something.
I don't see it too much because I'm mainly using kind of a nighttime dose when I'm doing it, unless they have a lot of adrenergic symptoms during the day. But if I'm really just trying to soften it and help them sleep and reduce their anxiety, so it varies. I haven't seen a lot. What about the two of you? You seen rebound?
I have seen it, but not so much in this population because of the way I use it. But yeah, of course, if you're on, 0.1 TID and you stop it suddenly, I see problems. But typically that's not how, I have some patients on that kind of dose, and I just warn them ahead of time. You don't need to run out, or, run out on Sunday when you might not be able to get a refill.
Think also, we're talking about using clonidine in some of our most adrenergic patients. Even if you haven't started a patient on clonidine, perhaps as Dr. Bateman referred to, they have too low of a blood pressure to even use an alpha blocker. You kind of find that even other orthostatic support measures, if you're using supplemental fluid and salt, pyridostigmine, midodrine-droxidopa, et cetera, you can be using those for orthostatic support that can sometimes bring down that adrenergic response to the physiological distress of orthostatic intolerance. But if you remove those medicines, suddenly you get the same rebound. And I think that is inherent to dysautonomia, not just specifically to one drug.
Something
I want to. Oh, go ahead.
Go ahead. Something I do that, probably you may do for other reasons for your patients, but in some patients who really have a hard time sleeping because of that autonomic overdrive, and maybe I've done the clonidine, done what I could to help in that way, I'll sometimes have them take a break every 2 or 3 hours, do meditation, get their feet up, try to deep breathe, relax, and kind of calm down that autonomic nervous system throughout the day. Because I think, sometimes when they have a worse day, they're, maybe they're having a busy day, or, things are going on, the more their autonomic nervous system revs up, the harder it is for them to sleep. So I'll try to have them periodically throughout the day kind of turn everything down.
That's good. I wanted to throw in a couple of comments. One is, remember, we're talking broad here, right? And what I want you to come away with is there's lots of things we can do to help sleep, right? So a lot of times we think, oh, I don't prescribe sleep drugs, but that's not really the point, right? It's a mystery. It's almost like trying to decide how to treat the whole illness. So you narrow it down to this big disturbance that's a part of all these illnesses, and see how creative you can be, right? Based on their presentation of their other conditions, and which of these underlying physiologic processes might be playing a role, or the biggest role, or can you get a handle on it? I wanted to add something, since I added HPA axis dysregulation. It's tempting to think to put people on cortisol or hydrocortisone because of that. But that is not, if you know your medicine and think about it, the adrenal glands are normal, at least in the studies so far in ME/CFS. So, you can do a stim test and show that if you give the right stimulus to the adrenals, they work just fine. If you put people on hydrocortisone or cortisol, you're going to cause adrenal suppression. And that makes all their symptoms worse, Plus, they have a dysregulated central system. They can't come back from adrenal suppression very well. Their ACTH may be sluggish and they aren't able to respond to that stressor. So although once in a while there's a situation, to use short, a short course of hydrocortisone or cortisol, don't be tempted to put people on chronic replacement therapy because it will seem really good for about 6 or 8 weeks, and then you're in deep doo-doo.
It's
That's a medical term.
I can't echo that enough. Agree.
Great points. I wanted to bring up one of the things I hear a lot from patients is I did a sleep study. I was diagnosed with obstructive sleep apnea and given a CPAP, but I can't tolerate it. It interrupts my sleep. I just can't do it. What do you talk with patients about when they don't tolerate that intervention that they've been told they need to do for improving oxygen during sleep or their breathing during sleep?
There's a lot, you can spend, and it should always be primary in your mind, right? First of all, you can help people understand what their options are for trying different masks. And it's also an appropriate time to try medications to help people sleep, right? And even sleep specialists are more liberal with medications once people have their CPAP in there to control their obstructive or central sleep apnea. And I don't abandon people I try not to abandon people when they simply can't do it, right? But help them see alternatives and jaw splints and bed positioning and even wearing oxygen overnight if it helps them, not dip their oxygen. There's sort of a conventional wisdom that there's no point in giving people oxygen if they have obstructive sleep apnea because they don't inhale. Well, that's not necessarily true, right? Because I've done overnight pulse ox, and you can show that with oxygen, they probably still have lots of obstructive events, but you can keep those low hypoxic episodes from occurring in many patients. So, and again, that's not a substitute for the well-established treatment, but it's adapting the best you can to the resources of the patient and sticking with them. Other thoughts, Dr. Hoppers and Yeoman?
I've done the same thing. I have a teenage patient who has obstructive sleep apnea and she cannot tolerate it. So we did oxygen and that's helped her quite a bit. Also, just again, think about getting the testing, right? I had another patient who is a young teen who I really, she just had all these sleep problems and she additionally had hallucinations. We did a sleep study. She had sleep apnea, put her on CPAP, and she no longer has hallucinations. So don't forget to look for it. We know that sleep is a problem in ME/CFS, but don't forget to think about, doing sleep studies and looking for those things, even in children, by the way.
Dr. Brown?
Yeah, as someone who deals with, I'm not sleep certified, sleep boarded, but I'm very much adjacent with my other part of my career, which is chronic neuromuscular failure. I feel like, unfortunately, people just sort of drop off a device and say good luck with a lot of those CPAP things. And you can't forget about the benefits of treating both, obstructive apnea and things like that, which include reduction of stroke and heart attack and other benefits, not just sleep quality. And then going back and sort of really piecing out what are the issues that they're having, agree with associated with medications, different masks. And then also remember, sometimes when you treat obstructive apnea, you can have emerging central apnea too. So when you treat them, so it's not a one and done, here you go kind of thing. And that's, unfortunately, our system is not great for dealing with that. So really working with a good sleep provider or someone who's very familiar with like the tips and tricks can make a huge difference. And sometimes I just tell people it takes time. Like, you're going to put this weird thing on your face. I do a lot of desensitization with patients, like in the evening, put on your favorite TV show or watch a movie or something with it on, and don't just slap the thing on your face, try to stare at the ceiling and wonder why you're not getting good sleep. So there's a break-in period. There are a lot of other variables, but I feel like often people give up on it really quickly without having really investigated the potential benefits, because it's not just for this. It can have a lot of other positive benefits as well.
Thank you for those points. Yeah, it's really, there's no, you're right, the system doesn't really have somebody to walk people through that process of getting used to it. It's just kind of, it seems like it's usually just handed off. Dr. Yeilman?
There are a couple other gems or points that I wanted to bring attention to here before we end. And one of them sort of comes out of the idea of treating obstructive sleep apnea, like we're talking about. It's important to remember the impact of positioning with sleep apnea, whether someone's on their back, on their side, whether they can use a body pillow or not to sort of support specific positioning that is better for good sleep quality. But I think that is a point that can be expanded upon because we do deal with a subset of patients in the ME/CFS long COVID world with neuroanatomical issues. And if you're wondering about that, sometimes just asking people to switch up their sleep position can be really enlightening. So I'll have people raise the head of their bed to 20 or 30 degrees and sleep in those positions, assuming you can do so without avoiding exacerbating lower back pain. You might find that people have less autonomic disruption in more upright positions or perhaps more supine positions if they're already upright. So having them play around with positioning, whether they're on their side, on their back, up or down, can really be enlightening in that way. I also think that we have a lot to learn about this, but there are many different sort of case reports from patients about duration of sleep and how sleep can be unrefreshing at 8 to 9 hours. That should be enough, right? But then all of a sudden you somehow successfully treat sleep or autonomic dysfunction and people can sleep for 11, 12, 13 hours. And if they do that consistently, I sometimes get reports that it's refreshing. And I wonder, and this is just spitballing, but when you think about sleep, it is a metabolically restorative process. And if we acknowledge that ME/CFS is a disorder with significant metabolic dysfunction, and we acknowledge that, in fact, there are studies when ATP is used up and you have a buildup of ADP that initiates sleep. If you imagine that in our patient population and then give them more time in a sort of metabolically disrupted process of sleep restoration, if you give them more time to go through it, just like they need maybe more time to recover from activities, that may be why people are experiencing some degree of restoration when they get enough hours. And so for some people, they really do get 12 hours of sleep every night. They have less hours awake, but the hours awake are much more functional and higher quality of life. And then I think also we talked about autonomic disruption through the lens of alpha blockers, beta blockers, benzodiazepines. There's a thing that I see in some of my patients. It's sort of an old rheumatology diagnosis called erythromelalgia, with swelling, redness, pain, tenderness in the extremities, and often happens at night. And I've found that I think that's really related to the underlying dysautonomia of these type of conditions. And a little midodrine or droxidopa, even at bedtime, yes, you have to watch for supine hypertension, but it's actually really effective for preventing that kind of pain, swelling, redness. And similarly, when we talk about restless legs, yes, looking for iron deficiency is important, et cetera. But there's a lot of small fiber polyneuropathy, and there's a lot of things that exacerbate that. So again, restoring hemodynamic flow can sometimes help with those sensory symptoms in the lower extremities, or reducing mast cell activation syndrome. Sometimes I'll put people on a ketotifen or a Benadryl even before bed, and you actually find that it reduces some of those lower extremity symptoms. So they may not always be typical restless legs, even though sometimes they clearly are.
Yeah, I've even used the pneumatic compression boots on the legs before bed for some patients to address some of the hemodynamic issues and reduce the pain in the legs. But then other people, they'll say that it wakes them up. So it's all individualized for each patient, figuring out what works. But I think you made a great point on bed positioning as well for those patients who are hypermobile. Oftentimes, when I'm in the clinic with patients who may have some craniocervical instability, we gently provide support on the neck. They'll report feeling that it's so much easier to breathe. And then when we remove that support, it becomes a lot harder to breathe, that the chest feels weighed down. And so in those patient populations, it's important to help support the cervical spine during sleep, because during sleep you may not recognize that your neck's twisted or turned in a way that's cutting off some of that blood flow and oxygen. Great discussion. Thank you, everyone, for joining. We can maybe tackle one more question or comment. You mentioned this in our discussion this morning, Dr. Bateman. We're talking about how some patients will report that when they lie down, that fluid has been down in their legs all day. And so then they lay down and now all that fluid's able to get back and they might have to go to the bathroom quite a bit. And you touched on one option, but you mentioned this morning about telling people to get horizontal before bed and get some of that fluid out. Can you touch on that?
Actually, yeah. I mean, actually, the reason I tell them to get horizontal a couple hours before bed is to minimize the adrenergic response, right? And to lower the norepinephrine and epinephrine levels. But it would also serve that purpose, right? And a lot of what's happening when people are upright is some people get actual edema, right? But lots of people just have venous congestion, which can resolve fairly quickly. And so I like to have people intermittently put their feet up during the day so that they kind of keep that blood circulating to the uphill places. But yeah, I mean, this is why you have to individualize, right? And it's also related to age. So many factors are different in young people versus middle age versus elderly. All those things need to be taken into account, and it sort of brings all of our skills as clinicians together, right, to help guide people about how to achieve the most restorative sleep possible given the difficult situation.
Thank you. Yeah, that great point. As far as we perhaps in a future discussion, we can talk about sleep positioning, posture, and things in more depth. But thank you, Dr. Bateman, and everyone who joined today. And our next session will be next month on April 7th at 12 p.m. Mountain Time. And it will be on cardiopulmonary exercise testing and metabolic dysfunction in long COVID. We'll have well-renowned experts Todd Davenport and Stacy Stevens from Workwell Foundation talking to us. Thank you, everyone.